OSCEs, which are basically practical exams, clinical exams, but all of them have been formative, which mean if you're at university or in some schools you use the same term as well. Basically just means that the exams don't count towards the final grade when you eventually graduate. They're basically just practice exams, but this one in January is my first summative exam, my first proper exam, and it counts towards the grade that I eventually walk away with at the end of my 5th year. So it has meant, unfortunately, that I've had to take a step back from the channel just to refocus myself. I was making a video every day about 2 or 3 months ago, then I decided to cut that back to about 2 videos a week, 2 to 3 videos a week, and I made the final decision to really just refocus myself on not necessarily what's important, because I do love this channel, but certainly what was important in the immediate present. Let's put it that way. And of course, at the end of my degree, I want to come away with the highest grade possible. So yeah, it's been an important last 28 days, really finalising my revision for the next month to come, and it is going to be the same. There's not going to be very many videos, maybe 1 or 2 here and there, like this one where we're just going to go through kind of the revision material, the notes, if you enjoy this video, that is. We're going to go through the notes that I've been making. So it's about 7:30 in the morning at the moment, nice and quiet, and I thought there's not really a better time to quietly and in a very relaxed manner go through the notes that I've been making over the past couple of months now. If you like making notes, beautiful notes, like I do, this not only is the video for you, but this is the program, the software for you. Notion is what I'm using for all those who are interested. I'll put a link in the description below, and it really is a very good tool for making notes. It's quite similar to OneNote, Microsoft OneNote, but not everyone has access to that, and secondly, it's not actually, personally anyway, I don't think it's as user-friendly as Notion. So you can see up here, Andrew's Notion, that is me, I am Andrew. served me relatively well until now. It served me well until now when, first of all, I want to do as well as I possibly can, so I'm trying to refine my revision technique as much as possible. But not only that, I've never had to deal with or learn the amount of information that I'm required to learn right now, and that's only going to get, I guess, worse, I suppose, but it's only going to get more intense in 4th year and in my final 5th year of medical school. So I've had to find a way that I can actually revisit my notes properly and navigate my notes in a way that means that I actually take something away from it rather than just rewriting and rewriting and rewriting. And thus, I found myself using Notion. It was introduced to me by a friend of mine, and I'm currently using it to actually go over my notes, and I think that is miraculous, very surprising. But yeah, I think we'll go on to respiratory disease today. So you've probably clicked on this video, and if you're still watching, I apologise. I'll probably put a timestamp as to when we actually start going through respiratory disease, because that is the one that is most filled out. So what we'll do is we'll jump into respiratory disease and take a look at what I personally think, at least for my university, are the most important respiratory diseases that you should know at least in 3rd year. Okay, so this is respiratory disease, and the way that I think we're going to do this is I'm going to be relearning, or I guess just revising, a lot of the topics we're about to go through. So do forgive me if it doesn't sound like I know exactly what I'm talking about all the time, or if I'm a bit unsure, and I refer you to look things up for yourself, because I am by no means an expert on any of these topics at all. Some of the information may not be perfectly correct in these conditions, so I always implore you to do your own revision as well, and especially if I'm unsure about something. So respiratory disease, as the name and the little image here suggests, that is everything to do with your respiratory system, basically starting at your mouth and nose, running down the trachea into your lungs. Respiratory disease is, pretty much entirely to do with this area, but it has a lot of effects, can have a lot of effects, especially chronic respiratory conditions, and some very serious acute respiratory diseases can have an effect elsewhere on the body, and there are also a lot of chronic conditions of other systems of the body that have secondary effects on the lungs. So it's just a good thing to think about before we start looking at some of these conditions. I'm also not sure how many of these we're going to get through together today, but we'll see how we get on. It's just a good thing to think about, because you might be thinking respiratory disease, things like asthma, COPD, if you've heard of that, pneumonia, if you're looking at this list. Let's actually get rid of this, maybe make it a little bit larger. You might be thinking, well, that is like having a cough, right? It's an infection, some sort of upper or lower respiratory tract infection. That's the lungs, basically. Kind of, not really, but it's part of that respiratory tract, right? You might think, well, cough has got something to do with pain in my legs, maybe, or sort of pain can be very common. Okay, so let's start off by taking a look at asthma. Now, many of you might be thinking asthma is a non-serious, non-life-threatening, kind of wheezy cough type condition that you get when you're young, and part of that is correct. It is seen very frequently in young people, but it is not non-serious and it's not non-life-threatening. It can be, and very frequently it is. It can be very well controlled. So long as you're compliant with your medication and you're kind of aware of the things that might be able to trigger your asthma, and you're just generally well informed about your condition. But for those unlucky few who have quite serious asthma or potentially serious asthma and do not control it well, it 100% can be very, very serious, and certainly life-threatening. So you guys can take a look at these. I will try to remember to put them in the description below. But these are my two favourite websites for learning what I need to learn, really. There are other websites that I use less frequently, but these are the two ones that I try to always refer to when I'm learning a new condition, specifically an actual condition. So a disease like asthma or something. So TheASMRMedic is a UK company, I believe. They do a lot of OSCE type stuff. So OSCE guides, these are my clinical guides. They do a lot of these clinical guides and they're very, very useful. This one is a clinical examination for the respiratory system, so go check that out for sure. And this one is specifically an OSCE guide, but they also do quite nice overviews of conditions as well, so I'll check out this link as well. This one is specifically for asthma, and then the second one that I look at a lot is AMBOS. Now this is a American company, or a website, and they do much more in-depth clinical overviews of conditions. So have a look at this. This page will really give you everything you need to know, at least to third year, probably as far into your foundation years as a doctor. Actually, it's really in depth, so you need to kind of pick and choose the information you take away from this one. So let's just get into the summary of asthma. So asthma is a chronic inflammatory disease characterized by bronchial hyperresponsiveness. So that's basically being allergic to things. The bronchioles being the branches of your trachea that go into your lungs. Episodic exacerbations, which are known as sort of asthma attacks more colloquially, and reversible airflow obstruction. And the reason that I've put reversible in italics and I've highlighted it is because that is incredibly relevant to asthma. So as compared to COPD, which is also a chronic obstructive disorder, it is also airflow obstruction. It is irreversible. So if you have COPD, chronic obstructive pulmonary disorder, differentiate asthma from COPD again. Intermittent obviously means it's on and off, and dyspnea means kind of dysregular or irregular breathing, either through a number of ways. It means that it can be just not, so it can just be pathological breathing, abnormal breathing, and by intermittent it literally just means, someone can be asthmatic and they're perfectly fine one moment, and then during an attack then they start the abnormal breathing, but it's reversible, as we know. So you have these periods of being fine, having normal breathing or non-abnormal breathing, and then periods of abnormal breathing through episodes, whereas someone with COPD. Okay, so moving on from the symptoms of asthma to diagnosis, the two main diagnostic parameters by which a diagnosis of asthma is made is something called a pulmonary function test and an allergy test, but it is mainly this pulmonary function test, as well as, and we will go into it in a bit more detail in a second when we go through the individual drop downs, but a diagnosis generally is made through, depending on the age of the patient, through the symptoms that they present with and the pulmonary function test, and we'll go into what that actually is in a bit. And an allergy test can be done as well. It's not really, I guess that's more for the type of diagnosis of asthma. You don't really need to do an allergy test for everyone who presents with asthma though, as far as I'm aware. So treatment options. These are the classic two classes of drugs. One is essentially a prophylactic, that is the inhaled corticosteroid, which just all corticosteroids are anti-inflammatories essentially, and they prevent the onset of symptoms, and an inhaled bronchodilator, such as I mentioned earlier, salbutamol. They are short-acting beta-2 agonists, and they essentially are for acute exacerbation, so when someone starts feeling symptoms, to reverse the airflow obstruction, to reverse the constriction of their airways, they do a quick short spray of salbutamol. It can be taken in multiple ways, but generally speaking, if someone is self-medicating, it's used through an inhaler, and they inhale the bronchodilator. And corticosteroids are usually, like I said, a long-term asthma control type thing, so budesonide, and that is given usually at regular intervals throughout the day, once or twice a day. Those are the two classic ones though. There are many different types, but I would say, if you are like me, a third year medical student, those are probably the ones that you need to know. To be honest, I don't think that I'd even need to know this. It's more salbutamol, which is why I've highlighted it. Everything that's been highlighted in pink are of particular importance. So this is quite interesting overview from osmosis that I would recommend taking a look at. I will do my best to just copy and paste every single link that I have on this page into the description for those who want to take a look. If you guys want these notes, I can have a little think about that. These take me obviously quite a long time to prepare, so we can maybe have a little think about that. Feel free to join the Discord if you maybe want like personal access to this or something, but I'm not quite ready to release my notes to just through like some sort of Google Documents link or Google Drive link on the YouTube page just yet, so probably have to have a little think about that if you do want them. So now the pathophysiology of asthma. So we've talked about it generally through the summary page, kind of what it is. It says bronchial hyperresponsiveness, episodic exacerbations, and critically reversible airflow obstruction. Asthma is reversible, as opposed to irreversible or maybe a younger patient, a sort of family history of A to B. From what, I mean, take this again with a pinch of salt, but from what I've seen and heard myself clinically, it's pretty much always asthma. It's pretty much always asthma. If they have eczema, hay fever, allergic rhinitis, or one or more of them, I'm immediately thinking, it's got to be asthma. Got to be asthma. Obviously, situations differ, and there are exceptions to the rule at times, but it's a very, very good one to remember. I'm gonna bolden these low exercise tolerance, so they can't exercise very much before they start huffing and puffing, or maybe experiencing some mild asthmatic symptoms. Diurnal variation, so that is to do with your sleep-wake cycle, basically. So symptoms and peak flow, which is a way of measuring your expiratory volume, how much you can breathe out. You can forcibly breathe out in a second. This will generally in asthmatics worsen at night or in the early morning, and unless they have an acute exacerbation of their asthma, will be generally less bothersome throughout the day. Throughout the middle of the day, it's okay. Then they try to fall asleep, they start coughing, or they wake up coughing. Things like that. Evidence of occupational asthma, so better on the days that they're not at work than the days that they are. Usually there'll be some sort of allergen at work. Maybe there's high levels of dust, or there's something in the air that's setting them off. And then signs, which are the sort of things that you see on examination generally. So not things that are immediately obvious via, I guess, when you take a history, or the symptoms that they're immediately presenting with. So on examination, you'll again experience a expiratory polyphonic, so kind of all over the place in terms of the pitch of the wheeze. A dry cough, which can be nocturnal, as we said. Tachypnea and hypoxia. Tachypnea is dyspnea generally, but tachypnea is specifically an increased respiration rate. So rather than a kind of all over the place breathing pattern, or one that's just generally abnormal, and hypoxia, which is a decrease in the oxygen saturation of their blood, which you will be able to tell through the O2 sat monitor. And like I said, that's generally an acute and relatively severe asthma as well. So for them to be presenting with quite a high respiration rate, and especially hypoxia, if they're presenting with hypoxia, you know that this is actually really quite serious now. So now moving on to some of those investigations that we alluded to earlier. As it says, several useful tests. There are several useful tests that you can use to investigate asthma. They demonstrate airway obstruction and airway inflammation, have suspected asthma due to their maybe history of exacerbations and their general signs and symptoms. Again, respiratory, basically all the same things, but at number 3 we have an FeNO test, which I have to admit I can't really remember what that is or what that entails. We have an explanation of all the tests here. So the FeNO is the measure of exhaled nitric oxide, which is a marker of eosinophilic inflammation. Fair enough. I completely forgot what that was. Let's take that off. You can get all of this stuff at the asthma page on TheASMRMedic. So yeah, go over there and you'll see that exact same table if you want to have a look at it in more detail. And the peak expiratory flow is monitored again 2 to 4 weeks if still uncertain after the exhaled nitric oxide test. Okay, cool, that's the investigations. You'll get some parameters in cases in a test. So it is good to know this in a bit more detail, but diagnostics, this is the fun part, in my opinion anyway. Adults, symptoms, and I mean, it's fun generally. Here it's pretty simple. For adults, it's the symptoms and positive investigations that we just talked about that give you the diagnosis. Say for children 5 to 16, and for under 5-year-old children, it is none of those types of symptoms, so you don't really need to do investigations. It is purely a kind of let's make the diagnosis, and then when they get older than 5 years old, we can do some more of those annoying tests. So the reviews are required regularly. Under 5 years old, investigations are then carried out when they are over 5 years old. So let's have a look at the differentials. So for those of you who aren't aware, differentials are the diagnoses that share some key symptoms or signs, or even investigatory tests that can make it a bit confusing and uncertain about which diagnosis to make. So these are the differential diagnoses: bronchiectasis, COPD, cystic fibrosis, general airway obstruction, pulmonary edema, GORD, which is, yes, I was there. I forgot that was for a second. Gastroesophageal reflux disease, or pulmonary embolism. So, and there are key differences between these. For example, this is not reversible with bronchodilators. Really, cystic fibrosis is a genetic disease. Bronchiectasis is to some degree also not really reversible. To some degree, airway obstruction, pulmonary edema. You can tell that through some of the signs by doing some sort of various amounts of respiratory investigations by tapping on their chest. GORD has a number of different presentations, and pulmonary embolism as well. So there are again some very key differences there that I implore you to go have a look yourself. Lastly, management. We've gone over this a little bit. There are some non-pharmacological ones, but when it comes to asthma, I think it's pretty loose, the amount of pharmacological interventions that we give. You know, it's not they don't have many side effects. Long-term corticosteroids can give you some very serious problems that are worth thinking about. So, but generally, if you're just thinking about a bronchodilator, yes, there's potential to give you sort of palpitations, but generally not today. I would say it's less of a problem. So non-pharmacologically, smoking cessation, weight loss, and methods to avoid triggers. So maybe is it possible for them to change job, or at least change an area that they're at work that could be triggering them. And then pharmacologically, we've talked about a little bit. Here is a link to the NICE pathway and an actual physical management NHS guidelines, and it's the sort of stepwise way that the doctors approach treatment for all diseases. And if you want a very, very well laid out explanation of what to give someone with asthma and when to give it, this is where you go. They are very boring to read. I don't really like reading them, but in terms of practicality, it doesn't really get any better. If you manage to get a nice guideline memorised in your brain, then congratulations, you are a robot. Seriously though, that would be really good. That is a perfect way to answer any question in an exam. Personally, there are obviously variations and things to consider, but that's really, really important. And like I said earlier, it's generally based on some kind of mix of or use of bronchodilators or anti-inflammatory inhaled corticosteroids. These being things like salbutamol, and these being things like, well, I put beclometazone there, but there's also that bucanazide or whatever it's called. But like I said, it's more important that you remember salbutamol. That is like the king of asthma relief medication. So mode of activity, mechanism of activity, the beta-2 agonism. We've talked about that already. Adverse effects, it can cause tremor. That's actually a really common. I forgot about that. That's very, very common. That's because your kind of the tremor that you see in your hands when you're cold or whatever, that works through beta-2 agonistic systemic effects. So by just constantly taking salbutamol, you're constantly you have this higher level of beta-2 agonistic activity in your body, on your nervous system, and it can cause a tremor, which can be annoying, but it can also just not be that bad at all. Tachycardia, palpitation, and cardiac dysarrhythmia. These things are less common these days because of how well we can target these things and monitor these things, but still can be an issue. Inhaled corticosteroids, now there are definitely some adverse effects that you get here. I actually really quite disappointingly haven't put it in, but I will tell you about it a little bit. So the mechanism of action, they work to reduce leukocytes proliferation and down-regulate pro-inflammatory cytokines, leukotrienes, chemokine production, like we talked about. It's all to achieve a general anti-inflammatory action systemically, and to reduce the reduction of mucosal inflammation, dilation of the airways, and generally reducing mucus secretion. The adverse effects I've put in bold and colour: oral candidiasis, which is this kind of foul smelling, and that is true actually. Now I think about it, that is quite common. Is this a fungal kind of infection in your? I think it's fungal. You might want to correct me on that. Of the mouth, of the tongue. You kind of get this layer on the tongue, and other than just being a bit gross, it's not that bad. I guess it can, in some very, very serious cases, lead to sort of a systemic infection, but that is really, really unlikely. Generally speaking, it's just annoying, and that is caused by what the steroids essentially can do to the growth pattern of different organisms, and a hoarse voice as well as with high doses. There is potentially adrenal suppression, which is kind of related to what I was about to say. Corticosteroids can cause all manner of issues long term. I mean, if you take them regularly long term, their action on the inflammatory system can cause all manner of autoimmune and destructive types of problems. It can cause things like osteoporosis. So yeah, it really is worth thinking about. There are a number of things that they can cause, and I would look up long-term corticosteroid use side effects yourself, because there are a number of them. So further therapeutic add-ons, these are really quite specific to cases, and I can't remember really ever being asked these specifically, but when symptoms remain uncontrolled through the above mechanisms or options, we have leukotriene receptor antagonists, LTRAs, to previous therapies, I suppose. Trial of additional drugs, Ltras, or yeah, like I said, high dose. I've put a note here, I don't know what this is. So I think this is kind of the things to remember in terms of management. I think. Oh no, I know this is inhaler technique. So one of our OSCEs, which is, like I said, just kind of a trial clinical scenario where they see, are you able basically to examine a patient in an effective and safe manner. One of these OSCEs is explaining inhaler technique to a patient, and I have long forgotten how to do that properly. My OSCE is in April, so I've got a good few months to learn all the different OSCE scenarios properly again. They were cancelled last year. Our practice ones were cancelled due to coronavirus, understandably. So, inhaler technique is basically just teaching a patient how to do it, and they should be, as I said, reviewed well with all patients, because that is one of the biggest issues with asthmatics, is the chronic spread of misinformation about how to use your inhaler, and it can really diminish your response or the effects of your treatment on preventing or in terms of exacerbations, relieving your symptoms. So the short-acting broncho beta-2 agonists, they show how to use the inhaler, understand that it treats the symptoms and not the disease. That's an important point, but it's mainly the technique that's important. The inhaled corticosteroids, I've put a spacer, should be